ready for video? Thanks for being here tonight. My name is Sandy Rice, and I'm a retired nurse practitioner in oncology and family practice. And I'm pleased to moderate this discussion and want to thank our panel of experts in insurance and healthcare, and I will introduce them in a moment. Is this okay? I look soft voice. I want to thank David Clark and Wendy Sherrill, my committee members, also the Tennessee Justice Center for handouts and technical support, the D.W. Wilson Community Center for the space, and the University of the South for the video equipment. We will be recording our discussion and sharing it with our elected officials. Let me describe the format for the evening. Would everyone please silence their cell phones? I will briefly describe the Better Care Reconciliation Act, which we will refer to as the Senate bill, and the process by which it is pending a vote. The American Health Care Act is the House bill which was sent to the Senate on May 4th. Each panelist will speak for 5 to 8 minutes about the effects and questions the bill raises in their area of expertise. The panel will then take questions from the audience, which you may either write and pass to me. There's some pads on the tables, or stand and ask. Our purpose tonight is to educate, provide input, and raise questions and concerns that should be addressed before a Senate vote. I hope that you will also feel empowered as individuals to write, call, and visit your representatives. The Senate bill would repeal and replace Obamacare, or the Affordable Care Act, which we'll refer to as the ACA. Currently, the Senate bill calls for a decrease of $774 billion in funding for Medicaid over the next decade. Medicaid covers 74 million people in the United States and 1.5 million people in Tennessee. This decrease would result in a loss of $4.4 billion to the Tennessee's TennCare budget over the next 10 years. Overall, the bill is projected to increase the number of uninsured in the United States by 22 million. As you may know, the legislation was drafted in closed meetings by only 13 senators. Normally, Senate committees hold hearings to learn from stakeholders and experts about the consequences that they may not have anticipated. This was not done, even though the Senate bill, one, will directly or indirectly affect the health care of millions of Americans. Number two, it impacts a business sector that accounts for nearly 1/6 of the U.S. economy. And number three, addresses matters of complex health policy. Let me go ahead and introduce our panel, starting from the far left. It's Nancy Silvertooth. She's a lifetime resident of Franklin County, where she was a circuit court clerk for many years. She is currently a certified enrollment counselor for ACA and Medicaid. Cheryl Lenkar is a certified women's health nurse practitioner, and she's done that for 26 years. She's worked in both publicly funded and privately insured hospital and outpatient settings, providing direct care to women throughout their life cycle. She is currently working with adolescents. Bill Zeckman has been state licensed to consult on and market health insurance since 1981. He was a registered agent with the ACA Federal Marketplace for 3 years until the underwriter, Humana, withdrew from offering policies in Tennessee. Kelly Gregory is a writer, speaker, and Air Force veteran involved with Moral Movement Tennessee, trying to bring health and healing to all Tennesseans. Kelly has been a stage 4 metastatic breast cancer patient for 6 years and is covered by TennCare. Dr. Carol Paris is a psychiatrist and president of Physicians for a National Health Program. She retired from clinical practice in 2014, having worked in private practice, community mental health, prison psychiatry, and academia. In the course of her experience, she has become an outspoken critic of the private insurance-based U.S. healthcare system. She stood up to a Senate Finance Reform Committee in 2009 and President Trump in March 2017. She has witnessed national health firsthand as a consultant in New Zealand. She will be embarking on a 3-city speaking tour in Alaska next month. So I'll go ahead and start with Nancy for your introduction.
Okay, thank you.
Comments.
I'm glad to be here to speak on behalf of health insurance for people that need it. I actually sign people up as a community volunteer. I started learning everything I could about the health insurance, the ACA, in January of 2013, and Donna Seeley from right here in Winchester, Tullahoma, a retired nurse practitioner, and who was working as a volunteer, I believe, at Partners in Health over here, the free clinic, started having meetings about the Affordable Care Act. And I started attending those meetings, wanting to learn everything I could to be able to help people with this insurance. I attended all the excuse me, the Tennessee Justice sessions that I could, learned everything I could about the insurance, and sometime I think in about 2014, Dr. Thomas Smith in Winchester, who was instrumental in starting our free clinic Volunteers in Medicine in Winchester, heard that I was learning about the Affordable Care Act and asked me if I would come and speak to his patients at this free clinic. Of course, they were coming there because they had no health insurance. So that got me started, and I was doing that, and the mayor gave me a little space there, a little office next to where he is to meet people and talk with them. And so that's what I do. And of course, right now that we're not in an open enrollment period, it's sort of slow, but I get calls mostly from people with problems that they didn't get their information sent in like they were supposed to, and they've been canceled or about to be canceled. People have problems with Medicaid, TennCare. I try to help those folks too, and that's one of the needs. And of course, I'm going to speak from the aspect of these actual people that all of us know that I deal with, and there's a need for, of course, expansion of Medicaid, taking care of people in the gap that just cannot, no matter how hard I try to find enough income for them to qualify for the tax credits, or find a relative that they can claim as a dependent or be claimed as a dependent to somehow get them qualified. No, some still are out there just uninsured because they fall in the gap. There are those people, and a big need is more actual in-person help for individuals. They're told by, if they go to the Human Services Department, they're told to just go online. And many of the people that I deal with don't have a computer, are not computer literate, and that's a shame. I feel like there's many people out there that don't have insurance or are having problems just because they're not able to get help. And of course, that comes from the objections to the Affordable Care Act, and actually, sadly, what our state has done instead of helping get rid of it. But anyway, I would just really love to see us do whatever. And this bill, of course, they're talking about. Right now, our situation, we have at least 280,000 people or more that are in the gap, not insured. That's bad enough. And the other situations, the lack of help. And then, of course, this bill is going to just make that a lot worse.
Hi, I'm Cheryl Lankart, and I've been a women's health nurse practitioner for 26 years, and so I've worked in various aspects of care, but I thought what I would do is start with ages 50 to 64. You can tell by looking at me, I might have a little bit of an interest in that age group. But anyway, there are about 25 million of us in this age group in the United States, and it's estimated that we will pay anywhere from 3 to 5 times more with the Senate bill than we are currently. And then an example that I can cite is that if someone's at the 350% poverty level, so 100% is poverty level, about $20,000 a year for a family of 4. For 24-year-olds, they would spend about 6% of their income for insurance with the Senate bill, whereas a 60-year-old would spend about 16% of their income. And then as far as women's health goes, currently under the law that we have, things like mammograms, pap smears, bone densities, colonoscopies are paid for. Okay? Insurance covers those things. With the change in the Senate bill, things like pap smears or mammograms may or may not be covered depending on the kind of insurance you get, because if you have to choose a plan with a large deductible, say $5,000 deductible, a mammogram runs about $200. A pap smear and HPV hybrid capture run about $150 every 3 years. A colonoscopy is more like $1,400. So you might have to pay out of pocket if you have a large deductible, or pay a certain percentage of that procedure's copay. So there is a loophole in this Senate bill where it's my understanding, and correct me if I'm wrong, that insurance companies can pick whichever state has the lowest standard, and then they can use that as a baseline for what they offer the person purchasing the insurance, which is us. So people who are employed, they think, well, my employer will cover most of it. But even with that, employer insurance, there are loopholes so that the employer can offer far less than is offered now under this particular bill, especially for baseline things like preventive care, like mammograms, pap smears. So now I'm going to go on to contraception, women's health. So we know that women use birth control for probably a good 30 years of their life, oftentimes. And currently, under the law at this time, there is no copay for birth control, meaning that, for example, if I were on birth control pills, my insurer that I work for, my insurance premium pays for all of my birth control pills for the month. So when I go to the pharmacy, I have what we would call a zero copay. I don't have to pay anything extra. My insurance has already picked that all up. Another advantage of the current law is that, let's say you want a long-term type reversible contraception. Let's say I'm in nursing school, for example, and I really don't want to have a baby for about 5 years, so I might want to get an intrauterine system like a Mirena, or I might want to get an Nexplanon, an implant in my arm or something. So those are now covered, okay? There are 18 forms of contraception which are covered. Even tubal ligations are covered, which they did not used to be. So if this is reversed, it's estimated that, say, a young woman who gets birth control pills every month will pay about 61% more for those birth control pills than she is now. And that if a woman wants to get, say, an intrauterine system or an Nexplanon implant or something like that, that will more than likely be out of pocket, because those run, the Nexplanon runs about $450 to get it put in, $450 to get it taken out in 3 years. An intrauterine system, which lasts anywhere from 5 to 10 years, depending on the type, is about $1,000, $1,100. So you can see, if you're a low-income, young, struggling person, that's a lot of money to put out from your own pocket that's not covered. So another thing that is important to keep in mind is, so we want to find out, okay, so what happened in the last 2 years when we had no copays for birth control? What happened when we had long-acting reversible contraception? How did society benefit or not benefit? Well, what happened was there was a 30-year low in unintended pregnancy, so it made a dramatic difference. What does that mean in turn? It means fewer teen pregnancies, fewer pregnancy terminations, mothers able to space their births farther apart so their body can recuperate between babies. It also means more family stability, because we know that when a mother is financially able to support her family, especially if she's a single mother, then the children are healthier, they get better health care, there's less stress in the family, there's less child abuse, there's less neglect. I mean, it just goes on down the line. You can see the ramifications for a very long time of women being able to appropriately space their families, or to achieve a goal like getting an education and being able to get a better job in the long run. So I think that contraceptive care is incredibly important as preventive care, and in the long run saves us as a society money. On to prenatal care now. So you're ready to have your baby, you're to that point in your life, and currently, under the current law, both your prenatal care, your labor and delivery care, your postpartum care, your breastfeeding support if you want to be a breastfeeding mother are all covered, and your newborns care are all covered currently. And that's a mandate, it's a law. In Tennessee, 50% of all babies born in Tennessee are born under Medicaid. So my understanding is, as the federal government pays less for Medicaid, then it shifts to the states paying more money for those patients. Well, some states may have more money than others, some may have more poor communities than others. We can tell by this statistic there's a lot of people in need if 50% of all babies are born under TennCare. So the other thing that could happen if the Senate bill is passed is that women who need to purchase their own insurance, let's say they're not insured by an employer, for example, or even if they are, that pregnancy can be considered a pre-existing condition. Well, we know they can't banish pre-existing conditions, but what they can do is bill you at a higher rate if you have a pre-existing condition. So if you enter being pregnant, that's considered a pre-existing condition. If you've had a prior cesarean, that was considered a pre-existing condition. So what happened prior to the Affordable Care Act is that women had to buy a rider or an extra piece of insurance so that their maternity care was covered. Oftentimes they had to wait anywhere from 1 to 6 months before that insurance would kick in. So that was problematic for women. So some of these riders were affordable, maybe $15 a month. Some were up to $1,600 a month depending on which part of the country you lived in and how expensive it was. So we know that prenatal care is important. I cannot tell you how critically important I think it is because I worked labor and delivery for many, many years in high-risk obstetrics also. Women are 5 times more likely to die if they do not get prenatal care. They're far more risk for diabetes, high blood pressure, complications with obesity and smoking. We all know that about 12% of all births in the United States are preterm. So if we can prevent preterm birth, we can prevent those babies from going into the newborn intensive care unit by taking better care of the mothers. That's a smart thing to do. We as women have not been replaced by incubators. We are still the best incubator there is for unborn babies unless there's something really big going on health-wise for mother or baby.
Sure,
So,
that sounds like a good place to stop.
yeah. So anyway, I think that's pretty much the gist of what I was going to say. Mhm. Okay.
Okay, Bill.
Okay, thank you. Once again, Bill Zachman. I've been a State Farm insurance agent in McMinnville for these many years, I think about 36. Very proud and privileged to work for what I think is the greatest insurance company in the world. But we at State Farm actually did our own private personal health insurance market underwriting up until probably 12 or 13 years ago. And it was just a struggle to make a profit, even to break even. So we bowed out of the market. But thanks to the ACA, I got to come back in the market as a registered federal agent for the exchange plans. Well, that lasted 3 years until Humana, which was our source in Tennessee, withdrew from the state. So I regret to say that I'm no longer able to help. Nancy, I appreciate the volunteers who came in, the counselors, the ACA facilitators. I really appreciate that. That is a labor of love, doing something like that, because I know of all of the very demanding training requirements and certification requirements. So I certainly thank you for that. I've had a lot of experiences in telling people, and this was always the worst part of my job, telling people that you do not qualify for health insurance because you have a pre-existing condition. And I understand the health insurance industry's standpoint on that, because if you come in with a chronic heart disorder, let's say, or diabetes, well, that's kind of like insuring a house that's already on fire. you know you're going to have a loss, and it could be a catastrophic loss. So that's why the industry, and I think logically said, you know, we cannot serve that part of the market. That's cruel, that's inhumane, but that's the basic economics of the situation. I thought one of the crowning virtues of the ACA was the elimination of the pre-existing condition exclusion. It was wonderful. You know, we brought over 12 million people into the health insurance market who didn't have health insurance previously, and I can't help but think that a very large segment of that was people who were just waiting outside the door. They couldn't get in. They couldn't get their ticket punched because of those pre-existing conditions. Heaven knows they're the people who need the coverage more than anybody. You know, they really, really need it. The ACA, in removing that huge, I think, morally loathsome feature of the private health insurance market, advanced the society. Don't overlook the value of the ACA in doing just that one thing. Now, with the AHCA, or with the what do you want to call it now, Trump care, or McConnell care, or I prefer to call it no care. As a matter of fact, you might say that from the Senate standpoint, you can call it we don't care. We just don't care. You know, our Congress critters have the best health insurance plan in the world, you know, without exception. It's great. But what about all the rest of us? And what about the poor, the vulnerable, those who have fallen through the safety net, those whom society has kind of kicked to the curb because we have relied on the Darwinian economics of private health insurance. Now, I'm a capitalist. You know, I've been accused of being a socialist, but I'm a capitalist. But I want to be realistic about it. Let's have capitalism with a humane soul. Let's put a soul in it, what do you say? The ACA did that by bringing the private health insurance market and the private health care providers into the big tent and providing the subsidies that help people who could not afford insurance at market rates. You know, the insurance companies could still charge market rates, no problem. But the subsidies enabled people to purchase the insurance. I was telling you that always the worst day in my insurance career was telling people that they did not qualify because of pre-existing conditions. I think there was one day that was probably a little worse than all the others, and that was when we were marketing the ACA plans. I had a widow. She became a widow at a fairly early age. She was probably in her mid-50s. She was working 3 jobs, regular jobs. Now, they were part-time jobs, house cleaning jobs. Working 3 jobs, doing the best she could with failing health. And I had to tell her, you're too poor to buy health insurance. These are the gappers, the people in the gap, that 280,000 people in Tennessee. You're too poor to qualify for subsidies. So where do you go? You know, you're just totally out. Well, briefly, I think before we start offering answers to the problems, I think we need to look at the major overriding question. And the major question is this: why is it here in the year 2017, in the United States of America, the most prosperous, the strongest, the most robust country in the world, the country that twice in 1 century saved the world from the forces of despotism and tyranny? In World War I, we saved the world. In World War II, we came back and saved the world again. This same country that put a man on the moon, we planted our flag on the moon, this same country that year in and year out scoops up more Nobel Prizes in physics, chemistry, medicine, physiology, economics than any other country. Why is it that we take such great pride in our accomplishments as a society that we cannot find a way to solve this health care problem? We boast that we have the best health care science and art in the world, and that's probably true. That's why we have medical tourism. That's why we have rich people in other countries coming to the United States for their surgery. or for their treatment. That's exactly what. They're the ones that can afford to get out and come here. So you have to ask, why is that? You know, we've solved a lot of problems, and you'd think this is a problem that could be solved. The question behind that question, there's always another question, you know. The question is, what is it about our political system that keeps us from doing that? Yeah, we've got a healthcare crisis, but we've got a political crisis. Now, I'm a free market capitalist. I love America. I consider myself a patriotic American. But here's the deal. Democracy, and I wouldn't have it any other way, democracy, like Winston Churchill said, after he was defeated for re-election, after leading Great Britain through its greatest existential crisis ever in defeating Nazi Germany, he made the remark that democracy is the worst system for human organization except for all the other systems. and you know, I tend to believe that's true. The problem we have is the political problem and the lack, in my opinion, this is just Bill Zeckman's opinion, of political leadership. It's a failure in leadership. It seems like the overwhelming imperative for our elected officials, I mean, this goes way over providing jobs, this goes way over the fundamental economic health of our country, this goes way over health care. The first priority is re-election. Nothing gets ahead of re-election. So I think until we can turn the corner and we can get a crop of candidates who are willing to undergo the ardors of an election campaign. Linda here, she's been through it. She knows what it's like to go through an election campaign. Some of you others have too, on different levels. You know, David, others. We're just going to have to get those candidates who have that humane spirit, the broad view of things, to be willing to run and to be willing to risk defeat. You know, I think there are things in this world that are worse than defeat at the polls. The last time, not the last time, time before last, I ran for re-election to the Warren County School Board. I thought I was beaten and came very close until all the absentees came in. I won by a whopping 14 votes, Nancy. Call me Landslide Bill. I won by 14 votes.
Bill, can you wrap that?
Yeah, but anyway, I think that problem's going to have to be solved before we can get to the other problems.
Okay, thank you. Thank you. Kelly?
Hello, I'm Kelly Gregory, and I'm here to talk about two specific segments of the population and how this Senate bill will impact on those segments. The two segments being ones that I can personally speak to, that segment being veterans, how veterans will be affected by this bill, and also how cancer patients will be affected by this bill. First, I will address the veterans issues, and then I will address the issues of cancer patients. Number one, there are quite a lot of misconceptions about the VA health system, and so I'm here to tell you about how the VA system does actually work. The VA hospital system is not a 360-degree service for health care. It does not encompass all and every bit of the health needs of an individual. It is a frontline care, and it is set up mostly to deal with the outcomes from service-related issues, and overwhelmingly of the male veterans. There's very little, precious little women's health care that goes on in the VA healthcare system. That means that most veterans, when they access health care, are not doing so through the VA. Fully, only 35% of veterans who are eligible for VA health care actually receive their health care through the VA. The vast majority, that means the vast majority of veterans are receiving their health care through various other means. Now, of those millions of veterans, a little over 2 million of them in the United States rely on Medicaid for their health care for a variety of reasons. A veteran could be going to Medicaid for their health care because they don't live in an area that is served by a VA hospital. Their VA hospital is understaffed and underfunded, and the wait times for the treatments that they need are too long. Also, you can, the VA, as I said before, does not offer the treatment that you need. And then also, you may be ineligible for VA treatment because your time in service was not long enough. So that means there are 2 million, as I said, 2 million veterans who rely on Medicaid. That gives you a little bit different picture of what the typical Medicaid patient is than what some may have assumed. There are 43,000 veterans in Tennessee who receive their health care through Medicaid. There are another 28,000 veterans who are in the coverage gap. Estimates on how many thousands of veterans would lose their health care if the Senate bill passes varies, but it is anywhere from 15 to 25,000 veterans would lose their health care. So that's the veterans portion of my brief. On the issue of cancer patients, cancer survivors, and how this will impact their care. I could give you a lot of statistics right now, but actually what I'm going to do is just ask you, who in here knows someone who has cancer? Okay. There you go. That's how it's going to affect cancer patients. What this bill does, the specific legislative language, okay, that we need to be paying attention to most. It does several things. On the issue of pre-existing conditions, this legislative language allows states to proffer waivers for pre-existing conditions, for the coverage of pre-existing conditions. Okay? So when say someone like, for example, Senator Lamar Alexander makes a statement to the press and says that this current Senate bill is just fine on pre-existing conditions, this is false. What this bill does, it still says you can't be turned down for insurance because you have a pre-existing condition. But it allows for that insurance company to refuse to cover anything related to that pre-existing condition, or to charge you an astronomical amount in order to cover that pre-existing condition. It also changes the process for a state receiving the waiver. Right now, a state, in order to get a waiver through the